Good afternoon, all of you. Thank you for joining us for the second and the last short policy panel organized by Americans for Tax Reform and by Property Right Alliance. I'm Lorenzo Montanari. I'm a director for the International Advocacy for ATR and also director for Property Right Alliance. So we are here to discuss innovation policy and health financing, a solution from free market advocate. So today we will try to let's say, to cover important issues that affect all of us as a citizen and healthcare consumer and a patient. So how should we develop, and in most of the case, how should we improve our healthcare system in a way we can keep it very efficient, affordable, accountable, and always driven by innovation? Because innovation is the only way we can improve our life. So we are here with a great free market advocate. We are here with Mayrides. I tried all day to pronounce your surname, but and with Daniel Mitchell. So we'll keep my introduction very short since we have only half an hour. So Mayrides is a president of Emoluva Partner, has more than 20 years of experience in healthcare government affairs, specializing in patient advocacy, medicine access program, and overall health policy. He had been working a lot in South America with the different governments, Peru and Bolivia. He has a master in international business from the Johns Hopkins University, and I will ask him to start the conversation and your presentation. Thank you.
Sure thing. Thank you, Lorenzo, for putting together this panel. It's a pleasure to be with all of you. Good afternoon. So after that short introduction of who I am, I'm just going to launch into it. Like every good prepared American, I had PowerPoint slides, but Barbara has said that, you know, part of the ERB meetings is just riffing it. So I think I'm going to do that, if that's okay.
Oh, you can use it.
No, that's okay. What I can do is give the talk, and then if you're interested in the PowerPoint, I can send that around. Would that be okay? Okay. Sure. So I'm going to focus on healthcare cost containment policies. I am going to focus my talk on why healthcare cost containment policies have become more common globally, especially when it comes to medicine. So I'm going to talk about how some of those policies are especially egregious when it comes to medicine's innovation, as well as medicine's access and availability. And then I'm going to end with a little bit of a call to action to all of you, because I think it's your voices that are welcome and real necessary in terms of providing leverage for all stakeholders to have more fruitful, stronger discourse with policymakers on these topics. I think it's basic common knowledge that healthcare costs are always up and to the right when you diagram and plot them out over time. This is certain for all countries, unless, of course, you've gone through some sustained economic hardship. We also are very familiar with what drives those costs. We are living longer lives. We are suffering through more chronic diseases. We have higher incomes. We have technology advances. And of course, we are covering more people in our healthcare system. So when you have more people accessing a wider variety of healthcare products and goods, you're always going to have that trend line of increasing healthcare costs up and to the right. In OECD nations, data from 2016 says that for the past 40 or 50 years, healthcare costs as a share of GDP have pretty much doubled to an average of 9% across OECD nations. We also know that the burden is really on the taxpayer when it comes to finding greater efficiencies in healthcare, which is really, really difficult to do. And I think all of these reasons are compelling arguments for policymakers to make that decision to really focus policies on healthcare cost containment. In the academic literature, when you look at healthcare cost containment, you can find many, many examples of how governments and payers seek to do this. In one study that was published just this year, there were 72 policies identified by researchers looking at price controls, looking at volume controls, looking at the way that markets are structured, and even looking at policies to infuse healthcare systems with more dollars. I think the point here is that there are many, many ways that governments and payers implement healthcare cost containment. Sorry, I'm a very dry throat right now.
Do you have enough water?
I don't. Thank you very much. So from an academic point of view, there's a lot of study, a lot of published studies looking at what policies work and what don't in healthcare cost containment. Of course, if you're looking at the daily newspaper, if you're looking online every day, what do you see in cost containment? You see the prices of medicines. So you don't see academic study X versus academic study Y. What you see is images of prescription pills on top of a pile of dollar bills or next to a piggy bank. In fact, there was a poll out just yesterday from Harvard School of Public Health and Politico saying that of the 54% of those interviewed who said that healthcare cost was a significant issue, 80% of them blame that on the high prices of medicines imposed by the drug companies. So I think, you know, you have on the one hand academic studies and then you have public perception. The truth about medicine spending is actually quite different. In 2016, the share of prescription medicines and healthcare costs was about 13% across industrialized nations. So you had 14% in Canada, 11% in the UK, but in the US, in Germany, in Japan, in Spain, it was about 13%. So it's pretty stable across industrialized nations. And that's forecasted to increase well into the future. So the line for medicine spending compared to the line for all healthcare costs is really going to remain kind of the same, where the real drivers of costs are the other services in healthcare, the institutional providers, and that's where you see really this drive in healthcare costs. Thank you so much.
Of course. You don't need a comment.
So you have this distinction between what's being studied, what governments and payers are implementing, and then you have sort of the discourse in the public square. And the reality of medicines being a small part of healthcare costs is something that is true 2 years ago, it's true today, and it's going to be true, you know, 5 and 10 years down the road. I want to shift gears a little bit and talk about what I think are the most egregious policies that are being implemented, being aimed at medicines and the prices of medicines. There's 6 of them, and so I hope you can bear with me as I try to explain each of them. But number 1 is international reference pricing. Number 2 is therapeutic or internal reference pricing. Number 3 is something called health technology assessment. Number 4 is mandatory price cuts. Number 5 is something you're all very familiar with, which is compulsory licensing and the threat of stealing IP. And then the last one is other discriminatory practices that are imposed on, you know, by governments and payers. International reference pricing is when countries use the prices of medicines in other countries to determine either statutorily or as a basis for negotiation the price of a medicine that they want to make available to their population. The problem with this is that poorer countries are overrepresented in the reference basket. So while IRP is very common across, for example, Europe, you're going to see in each basket that there's going to be a price of that medicine from Greece. And I think that that's one problem. The real threat that we're seeing in terms of international reference pricing is actually coming from my home country, the United States, where the Trump administration has proposed an international price index. So this is something that will affect the prices of drugs offered in Medicare Part B, I'm sorry. These are the services and drugs that are provided by physicians in their offices. The idea of the Trump IPI is that they would save 30% over a 5-year implementation period, and that they would reference prices from 14 countries, many of them from Europe, or they would just copy what Germany is doing. And I think in the analysis there is no information about what's the rationale behind choosing these 14 countries? Why would we follow the German model in terms of which countries they reference? And there's absolutely no analysis in terms of what this would do for US leadership in terms of innovative medicines and free market-based reforms. In terms of internal therapeutic pricing, what governments and payers try to do is say, okay, we accept that through our regulatory process this drug works, but it's a cardiovascular drug and we already have drugs to treat heart disease. So what we're going to do is we're going to start with a price where our price point is already on the older heart medicines, and then we'll sort of go from there. The problem with this is that, as you all know, innovation is frequently incremental in healthcare. So when you are making a new medicine, you are building on what you've learned off from the old medicine. And your new medicine is typically going to be better for the patient in terms of dosing, in terms of convenience, and potentially even for a whole subpopulation of those patients. So having this kind of internal reference pricing and putting it into a therapeutic class and starting at that point for the price really dissolves any future incentive to bring a better medicine to market. The third big, and each of these topics is worthy of its own session, but the third big issue is health technology assessment. And these are appraisal processes that governments and payers put into place to look at a new medicine, to look at a new health technology, using a predetermined methodology where you kind of go through this process and it grinds out this number that then is the economic value of the medicine in the context of the healthcare system. Then what you do is you take this economic value, and this is supposed to be one input out of many that governments then decide, we're going to reimburse the medicine, but we're going to reimburse it at this price given this economic value that went through this big process. The issue with, as we colloquially call it, HTA, is that the governance, the participation, effective participation of stakeholders, and some of the methodology is always highly contextual. So take, for example, thresholds that have to be defined to know whether a medicine is worth investing or not as a government. Those thresholds are really too low for most innovative medicines. I'm thinking about the process that exists in the UK, where most innovative medicines just do not pass the litmus test and are either not reimbursed or are used as a negotiating ploy by governments to get the companies to lower the prices. The other problem is with effective participation. So if you don't have all of the stakeholders in the process, if you don't have the patient community, for example, participating in the HTA process, they have a different kind of view on the value of a medicine. And in most HTA processes, only lip service is given to patient participation. The fourth policy, which is particularly egregious around cost containment aimed at medicines, is mandatory price cuts. The best example I can give now is from Japan last year, where they reformed the way that they pay for innovative medicines. They used to have, and they still have, a price premium program where innovative medicines are sort of spared from the drastic price cuts that the government imposes every year across the board on all drugs. What they did was to reform this, and so only a few of those innovative medicines are now protected. They gave no rhyme or reason for the policy. A lot of it was done behind closed doors. And there are other requirements that favor Japanese producers over multinational companies. So this has become a big problem for innovative medicines and something that we as stakeholder community should be addressing. The fifth policy is on compulsory licensing. You're all familiar with that. Stealing the patent, using the pretext of a public health emergency, and saying that we need to really provide this to our patients and the price is too high. Compulsory licensing has been an issue in Colombia, in Peru, in Chile, in El Salvador for a number of years, in Latin America, but it's also an issue in Malaysia, in Indonesia, and in the Middle East, an issue in Saudi Arabia as well. I won't go into the details on CLs because you all know it very well, but it continues to be an increasing problem for innovative medicines. And then finally, I'll just say a couple words about discriminatory practices. These are other measures that governments put into place to kind of rig the market against multinational companies. And what happens is that at the end of the day, it's the patient who loses. So for many years, my last job was with a pharmaceutical firm. We specialize in rare diseases, and we were trying to launch a medicine in Argentina. And one of the localization measures in Argentina is that you have to test the product when it comes into the market. So you have to have your own laboratory, or you have to contract with a third party. But it can't be a contract with, you know, someone who already has a lab. It has to be your own investment. Well, at the end of the day, when we did the analysis, we were going to spend about $50 million just to build the lab and have these products tested when they're already being tested at the international level prior to shipment, according to international harmonization guidelines. So for us, we just walked away from the market. And I think today that drug is really, really hard to find in Argentina for, again, it's a rare disease, so not a lot of patients, but for the patients who do need it, it's increasingly hard to find in Argentina. So that's a very quick overview of 6 policies that I think are something that you guys should be focused on. The point is that the barriers to patient access to innovative medicines are serious and are increasing. I think you guys have the kinds of voices, you're organized, you work well together, you put the data together, you're very good with argumentation. And I think your voice is necessary to provide and help other kinds of stakeholders who are more directly involved to have more leverage in the discussions with policymakers on these important topics. So with that, thank you, and pass the microphone.
Thank you, Mo. I think your insight, your presentation explained pretty well how phenomena like compulsory licensing, but also reducing the drug pricing that has been implemented by different governments, that they are acting as a free rider. They are basically also a very high cost for the American society and American consumer as well. So thank you for that. We are moving to Daniel Mitchell. Daniel Mitchell is, I think, is one of the most interesting and libertarian economists in our environment in the United States. He's always very provocative, and he has a PhD in economics from the George Mason University. He used to be senior fellow of the Cato Institute, and now he's the president and founder of the Center for Freedom and Prosperity. And his presentation will be focused on government intervention and third-party players. So we are listening now how a think tank should fix this problem of drug pricing or compulsory licensing, and how to focus on innovation policy. Thank you.
Thank you. What I'm going to do, assuming I get my PowerPoint presentation up, is talk a little bit about the economics. And while I'm waiting for the PowerPoint presentation, I'll tie this directly into what we just heard. If we want new medicines, the people who develop the medicines have to recover their costs, all the experimentation, all the failed experiments, and if they're not able to cover their cost and earn a return, guess what? They're not going to innovate anymore. That's simple economics 101. And what I'm going to do is talk about this economics 101 in the context of the broader healthcare arena. And the way to start thinking about it is that in a normal market, if I want to go out and buy a bottle of water, I'm a consumer spending my own money directly dealing with a merchant who obviously has an incentive to make a profit, which means he has to compete against other merchants and offer me good prices, good quality, good service. In other words, we're both dealing with our own money. We both have an incentive to maximize what we value. But what happens in healthcare? I'll give the United States as an example, because we have both of the pathologies that I'm talking about. In the United States, most workers don't deal directly with a healthcare provider. Instead, they deal with their employer. Their employer deals with the health insurance company, and the health insurance company then deals with the providers. In other words, normal market forces are not allowed to operate. Now that's for the half of our healthcare spending that's run through the private sector, and I really should put private sector in quotes because it's not allowed, because of government intervention, it's not allowed to function the way a normal market transactions, normal market transactions take place. Well, what about the half of our healthcare that is directly financed by government in the United States? Well, once again, it's not a consumer directly dealing with a provider. Instead, what happens is that the consumer deals with a politician, and you know how indirect that relationship can be, and usually it's special interests, not consumers, that have the real control there. The politicians then pass laws and deal with bureaucracies that oversee the system, and then the bureaucracies deal with the healthcare sector, the doctors, the hospitals, things like that. Now, here's one thing to understand with either one of those two models I just described. Milton Friedman famously has this quadrant that he discusses where he says that if you're spending your own money on yourself, you care a lot about how much something costs and the quality of what you're getting. But if you're spending someone else's money on yourself, you just care about quality, you don't care about cost. And if you wind up dealing with spending someone else's money on someone else, you don't care about cost or quality. Well, what we have with our healthcare sector in the United States. All right, so here's Milton Friedman's matrix. And basically, normal consumers deal in quadrant 1. Third-party payer, which is pervasive in healthcare, especially in the United States, they deal in quadrant 2. But employers buy our healthcare in quadrant 3, and politicians buy in quadrant 4. In other words, we do not have a normal functioning market in healthcare. So instead of a consumer dealing with a merchant, we have something much more complicated. So instead of a normal consumer, let's think about a healthcare consumer. Well, no, this is a mental healthcare consumer. Let's talk about someone who has a physical sickness. So if you're physically sick in America, what do? Well, as I said, if you're most workers with a health insurance policy designed by government, controlled through the tax code by government, you deal with employers, insurance companies, and then providers. If you're dealing with government programs like Medicare and Medicaid, you're dealing with politicians, bureaucrats, and then providers. That system doesn't work very well. This is actually a picture of our health, and it's actually much worse than those pictures. This is our healthcare system after Obamacare. And by the way, Obamacare was just an incremental change. We already, prior to Obamacare, had a very government-controlled healthcare. I assume I'm loud enough that no one really needs this, but this is how complicated it got, and it was already complicated to start with. Here's the bottom line. I think this is the most important chart in our healthcare debate in the United States. Consumers today only pay 10.5 cents directly out of every healthcare dollar. Now think about that. If Barbara said, Dan, I'm going to pay 89.5% of your dinner bill tonight, am I going to go to my usual restaurant, McDonald's? No, Barbara said she's going to pay 89.5% of my meal. I'm going to find the nicest steakhouse in all of Moldova. I might even have to drive to a faraway city. Third-party payer is a major problem in our healthcare system. Here's a chart, you won't be able to read it, but it shows how some things like televisions, computers, phones, clothing, they're all going down in price. Whereas we have some things like college tuition and healthcare that are going up in price. What's the difference between these different sectors of our economy, some of which are the prices go up and some of the prices go down? The difference is that the subsidized ones, the prices go up. Again, someone else is paying for you when you go to buy something, or at least they're subsidizing what you're buying. There's no incentive on the part of providers to lower their prices or to compete. And that third-party payer system is a major challenge. Now, here's another way of looking at it. And pay attention to the purple line. The blue line is medical care. The green line is physician services. The red line is the average of consumer prices. But look at the purple line, cosmetic services. That's a healthcare procedure. Why is that growing slower than average inflation? Because that's a place where people actually spend their own money. In other words, they're in quadrant 1. Here's another way of looking at it. Overall CPI, this is between 1998 and 2014. Overall CPI, almost 46%. Overall medical care was almost twice as rapid, 88.5%. But look at all those cosmetic procedures. The quality is going up, and the price is going down. In other words, there's not something inherent in our healthcare sector where prices always have to go up. You only get the inefficiency, the higher prices, the bureaucracy, the complexity when government has stuck its visible foot in place of the invisible hand of the marketplace. So I just wanted to get out those basic economic concepts because we are never going to cure our healthcare problems either in the United States or elsewhere in the world until we allow market forces to operate. And bringing it back to what we heard from Mo, if we all want to live longer and have higher quality medicines, we better not simply sit back and hope and pray that somehow politicians and bureaucrats will take care of us. If we want better lives, better medicines, we need to restore and have market forces operating. And I'm terrified of the thought that we'll have more price controls, more regulations, more red tape, because then innovation, I think, will grind to a halt. Thank you.
Thank you, Daniel, for this outstanding presentation, for showing us how every time the government interferes with the market, destroy basic quality innovation. We have, I think, 10 minutes for, and I would like to open up the Q&A session. So please ask questions. I think it's a very interesting topic that will affect us as a citizen, as a patient, as a healthcare consumer. So the floor is yours now.
Thank you. Thank you both for your presentation. My question is to Dan. Dan, what do you think about co-payment as a short-term policy instead of, for example, full privatization in order to surpass this moral hazard that you were mentioned?
The way I usually answer that question is by giving the example of homeowners insurance and auto insurance. I have auto insurance. When I change my oil, do I submit a form to the insurance company? No. When I fill my tank up with gas, do I submit a form to the insurance company? No. I have homeowners insurance. If I repaint my dining room, do I submit a form? No. If I buy a new couch for the TV room, do I submit a form? No. Those are insurance policies for large, unexpected costs. My house burns down. Chris Lingle gets in my car and I can't get the odor out. Something like that. Well, our health insurance policies are done, it's in effect prepaid all-you-can-eat buffet for health care. So I have 3 kids. They're all grown up now, but when they were young, I was always going to the pediatrician, sore throats, earaches. I never looked at the bill. I never cared. Because I knew I had a certain, yeah, there was co-pays, but there was a maximum that I could hit. And so I was buying health care with someone else's money. Now, in some sense, it was my money because that was part of my compensation from my employer. But it wasn't compensation that I controlled. I didn't pick the insurance policy. Instead, it's like you're giving me your credit card and I'm going out and buying things. And so did the pediatrician have an incentive to charge competitive prices? Who knows? Because nobody bothers to comparison shop. So co-pays, I mean, if you listen to the 6 proposals that Mo was discussing, these are all indirect, backdoor ways of dealing with a problem that's caused by the absence of market forces in the first place. So maybe co-pays are good if you're sort of stuck in that box. But what I'm saying is that so long as we're stuck in that box, we're going to always be playing defense, always be dealing with politicians who are demagoguing. They're pretending to be our friend. Oh, greedy, doctors, greedy hospitals, greedy pharmaceutical companies are all trying to rip us off. Why don't we talk about greedy computer companies? We don't, because we're constantly getting better products at lower prices because market forces operate. And that's, that's the whole approach I'm taking to this is get back to economics 101, and we're so far away from that in most countries.
Thank you, Dan. We still have 5 minutes for questions. So.
I would actually only suggest that the European Resource Bank or the European think tank movement should join forces and focus also on private healthcare and make sure that governments get out of this. We have just done something in Austria with the social security and also healthcare, the 21 insurances that we have, 21 public insurances that we have, and we cut them down to at least 5. So this is the first major step of reform to bring in more private services. So I think this is something that we could do with also the taxpayers group across the country, and maybe we can sit down over dinner, break, lunch, whenever, in the bus tomorrow, and strategize for a plan, and also set up a letter that we could co-sign together and make people aware of what is coming up. Especially compulsory licensing will be a big threat to us.
Yeah, and I think the one issue that I mentioned, which is the Trump administration and the IPI model that they're trying to basically import from Europe, I think it would be very powerful for ERB and the groups here in this room and your colleagues worldwide. You know, one of the ideas is, would you be willing to sign a letter actually thanking the United States for its leadership in innovative medicines and innovations around free market reforms and what they're trying to do, but in that way also say, why are you importing a policy that doesn't work, or the policy that's dangerous to your own innovation? I think there's very little understanding. As I said in the analysis, there's absolutely nothing about U.S. leadership in this area, and I think it's something that you guys can take a very powerful leadership role in pointing out that contradiction.
Okay, I have the first suggestion to make. When Ignacy is doing the filming, maybe we do also all statements on that issue and just add them together. And I think this would be a good opportunity. Besides, many of us are speaking in the US and telling them not fall into the European traps and mistakes.
In Germany, we have a funny situation. So if you're a civil servant, you have a kind of private health insurance paid by the government. If you're an employee, you must earn more than 60,750 euro per year, then you're allowed to move into the private health insurance system. So at least what we could demand in Germany is that it should be open. That's your choice. Like we would love to have it in the pension system too, but it's not, you're not free in Germany. You have no choice. If you earn enough as an employee, you can change to a private healthcare system, but if you have less than the 60,750 euro, you're obligated to stay in the public healthcare system, and I think that's not a competition. And the second topic, what is important to us, in former years we had a competition between the governmental healthcare system as insurances. Now we don't have. The rates are all the same. So it's nonsense. So there are differences in services, but there should be a competition between them. Otherwise, it's one insurance is enough. So that's a really bad development in Germany.
Behind you.
Behind.
Thank you. I'm Octavian from Romania. On a nice TV post, it's called Entertainment TV, an exclamation mark. And there is a TV show which is called Botched. There are two famous plastic surgeons from America, Terry DeBro and Paul Nassif, making repairment operations of botched people that suffered unfortunate interventions prior to their repairings. As far as I understand from the presentation, the whole mixed health system is botched. And if you can get into an imaginary surgical room with a knife in your hand, and that knife is called Economics 101, what would be a precise sequence of operation you can do in order to repair the botched system? Because in surgical procedures, the sequence of operations is critical for the success of the operation. Thank you.
Putting toothpaste back in a tube is not easy. And that's, we really have several different things we have to do. On the so-called private part of our healthcare system, there was actually one good provision of Obamacare. It was going to cap the healthcare exclusion in the tax code, and that's what enables people to get compensation tax-free, so long as the compensation is used to provide a healthcare policy. And that encourages the overinsurance, and it encourages people to have this all-you-can-eat buffet approach to healthcare. So by capping the healthcare exclusion and ideally letting it begin to sort of fade out over time because of inflation, that would have in effect, I think, pushed the healthcare market closer to what we see with homeowners and auto, where people actually got insurance for genuine, large, unexpected costs and not for routine day-to-day medical expenses. Now, that's in the so-called private half of our healthcare system. In the government half, I actually think Republicans, before they decided to throw in the towel, they had pretty good ideas on dealing with entitlement reform, block granting Medicaid, which is our government-run healthcare for poor people, block granting that to the states, and then shifting Medicare, which is our government-run healthcare for old people, shifting that to a premium support system, in effect saying, okay, we're spending X amount of dollars on you, we're going to give that to you, and you're responsible for choosing from an approved healthcare plan, which is basically the system we have for federal government employees. So it's a very well-established system that actually works reasonably well by American healthcare standards. So it's not like there's one silver bullet. We have tentacles of government intervention all throughout our healthcare system, and you have to sort of slowly tug those tentacles out and begin to let market forces come back in. But here's the bad part. People are terrified because they see healthcare costs going up and up and up, and so they keep going to Washington year after year after year saying, you need to cover more of these costs for us, but that's, of course, what's driving the healthcare costs higher. And when you're telling them, we're going to remove some of this government intervention, they think, oh my God, healthcare costs will still go up. And frankly, when I tell them, oh no, look at cosmetic surgery, costs come down, that doesn't really convince them. And actually, you know what we really need? And maybe one of the groups here can do it. I have never seen a high-quality ranking, sort of like the Tax Foundation does the international tax competitiveness. We ought to have an international ranking of the degrees of intervention in healthcare. People tell me that Switzerland's more free market than the U.S. Are they? Maybe they're more free market on 4 ways and they're less free market in 3 ways. Maybe France is the most government run, but nobody knows. It would be actually very helpful to have that kind of ranking. It would probably teach us a lot.
Thank you, Dan, for this idea. Actually, we should, I think this short policy panel could be considered as a call for action on these issues, and I really agree with you that we should really work together as a think tank to face this and to work a lot on pushing for more innovation, more IP, and more free market policy. I think that we are ending the policy panel. I know that there is a great coffee break. I want just to take the opportunity that to also to promote the Property Right Alliance. We have been working a lot all over the world to promote IP innovation, and for April 26 is the World IP Day. We are working now to launch a first draft of the coalition letter, and we would like to send to Dr. Francis Gehry, the director of WIPO, the World Intellectual Property Organization. So I would like to have your contact and a collective signature. With Barbara, we have been doing this for years. So it's also an opportunity to work together and to promote innovation and IP. Thank you, all of you, and thank you all for Barbara and all of you for.
Thank you, Lorenzo, for, applause first.